degree from UAMS with a bachelor's degree in biology from Syracuse University. He completed his urology residency at the University of Mississippi Medical Center, and after residency, he completed a one-year robotic and laparoscopic surgery fellowship at the Swedish Medical Center in Seattle, Washington. And then I'll turn it over to Dr. Heulitt.
Thank you, Karen. I want to thank the Arkansas Prostate Cancer Foundation for letting me talk during this first combined talk. It's an honor. So Kara sort of went through the about me and sort of why I can get up here and give you guys a talk about prostate cancer. They sort of tasked me with not an easy task, but to kind of go through from diagnosis to treatment of prostate cancer, which is a pretty broad topic. Almost every slide could be a talk in itself, but we'll work through it, and then at the end, obviously, we can answer any sort of specific questions that you might have. So first off, prostate cancer screening. What does that consist of? Well, that consists of two things. A digital rectal exam that we perform in the office, and a PSA. The DRE is abnormal if we feel a lump or bump on the prostate, and then the PSA is abnormal if it's elevated. A little bit about PSA. So it's detectable in every male that has a prostate. I have a certain PSA level. It's a sensitive test, but it's not a specific test. So causes for elevation could be the prostate size, prostate inflammation, urinary retention. It's not affected by somebody's diet, or if they've been fasting or not fasting, or their renal function. What is a normal level? Well, broadly, a normal level is less than 4, and that's what it sort of says on the lab work, but it kind of depends on your age and certain other factors, but sort of broadly speaking, less than 4. Like I say here, it's argued about as prostate cancer can be found in men with a normal PSA range. If you biopsied everybody, you'd find prostate cancer in men with PSAs of 1 or 1.5 or something like that. So you can't just use PSA. So because of that, some doctors use different ranges as normal. So what do we do if your PSA is elevated? Well, the sort of gold standard and what we talk about is a prostate biopsy. This is really the only way to definitively diagnose prostate cancer. And it's the usual sort of recommended step if you've not had a prior negative biopsy, or if you're 70 years or older. We can talk about specifics on that. Another thing that's sort of come around more recently that we consider in some men is a multiparametric MRI of the prostate. This by itself doesn't diagnose prostate cancer, but it's good at helping us find lesions within the prostate. These lesions are usually higher risk type prostate cancer, Gleason 4 and 5 pattern type prostate cancer. And so in certain individuals, it might be a benefit to get an MRI of their prostate before getting a biopsy, or maybe before a second biopsy. And then there's sort of advanced lab work. And 4K score, PHI's Prostate Health Index, Select MDX, there's a whole variety of them coming on the market. They all help us sort of risk stratify patients in trying to consider whether or not they need a biopsy potentially. So what is the prostate biopsy? Well, generally we perform this transrectally through a patient's backside with ultrasound guidance. We take 12 cores or samples from 6 different aspects of the prostate. It is a random sampling, essentially. We don't like to say that or use that term really, but we're not finding cancer or seeing cancer on the ultrasound when we're doing the biopsies. We're hitting certain anatomic regions, and that's what the ultrasound is for. It's helping us ensure that we're hitting these certain regions of the prostate. Here's examples of cores or these needle biopsies that are taken. They're obviously not that big. They're fairly small, bigger than a human hair, but smaller than a piece of spaghetti. This is it sort of zoomed in at what a pathologist might see when they're looking under the microscope at the individual cores. So, let's say you've had a prostate biopsy and you get a pathology report. And that pathology report is going to have certain key components to it that you would review with your urologist. One of those is a Gleason score, and we'll go into depth about that. The number of cores that were taken, how many of those were positive for cancer, how much of the individual core was positive for cancer, and then things, something called perineural invasion, which sort of denotes aggressiveness when we look at it under the microscope. Gleason score is a number that the pathologist gives it when they look under the microscope. And it's anywhere from 3 to 5. And we're trying to actually sort of move away from Gleason score and sort of talk about group grade score, so that it would be 1 would be the lowest. Because some patients, I think, get confused. They hear they have a Gleason 6 or Gleason 3+3 prostate cancer. And they think they're kind of in the middle of the road if there's out of 10. But really, you're talking about Gleason score. The lowest score you can have and still have cancer is 3 or 3+3. Let me show you on this side. So that first number that we're talking about with the Gleason score is the primary or dominant component that's seen. So again, back on that core, when the pathologist is looking at those slides of the cancer that they see, what's primarily there that they're looking at? And do they see any sort of secondary component? Is there pattern 4 or pattern 5 in a smaller amount that's still there? Well, that's what would go in that secondary component. So for example, you might have a Gleason score of 3+4. So your primary pattern would be Gleason score of 3. But you might see some pattern 4 there, or the pathologist does, so it would be a 3+4. Someone that has a 3+3 Gleason score, that's only pattern 3 that's seen. But again, we report both of these numbers for consistency, so that's why you see the number duplicated. So after your biopsy and positive biopsy, you then look at a patient's PSA, their Gleason score, group grade score, their clinical staging, where we've felt the prostate, do we feel any lumps or bumps, and you put them into what we call AUA, or American Urologic Association, risk stratification. And so you're going to fall into one of these categories. Either you have very low risk prostate cancer, low risk, intermediate risk, or high risk prostate cancer. And this is sort of what's helping guide us about sort of next steps, next options, treatment options. And so it's important to sort of risk stratify somebody into the appropriate group. The other thing that's that we use at Arkansas Urology, and I think there's a benefit to, is genetic testing. So within each group, you can imagine that people are on a spectrum. Not everyone is right in the middle of low risk, let's say. Some people might have only one core with a small amount of cancer. Other people might have multiple cores. So how do you then try to help further risk stratify these people to understand where they are within that group? Well, genetic testing is doing that in some ways. We have our pathologists decide on the genetic tests that are appropriate based off of the amount of cancer and grade of cancer, and we use this information when counseling with our patients about their cancer and about sort of treatment options and next steps. And some examples of these, Polaris, Oncotype, or P10 are examples of genetic testing that's on the market that we use. So you have a positive prostate biopsy, now what? So depending on multiple factors, and even after taking into account these multiple factors, you likely still have options. And that's what I'll sort of stress throughout this talk, is that prostate cancer is a cancer where you do have options in general. Unless you're really on an extreme, generally speaking, you have options with regards to your treatment. So we'll discuss the options available based on their risk stratification in general, but this again is not absolute. So for the AUA, very low risk or low risk patients, so generally speaking, Gleason 3+3, PSA less than 10, and no nodule or a very small nodule on their prostate. prostate, they qualify for active surveillance, radiation therapy, surgery, or a category that I'd call other or focal therapy for their prostate cancer. For the AUA intermediate risk patients, active surveillance is still on there, but that's controversial. Some people are pushing the boundaries and trying to do favorable risk, intermediate risk patients do active surveillance, but I think the data is not as good. I personally don't, or I don't unless the patient is really wanting to. The other options for intermediate risk is radiation therapy with androgen deprivation therapy, surgery, and then that other category that we'll talk about a little bit. And then the AUA high-risk patients, usually radiation therapy with androgen deprivation, surgery. And this is all assuming that we've done testing and shown that these patients don't have metastatic disease or cancer that's spread outside the prostate. And that's a whole different talk. So we'll dive into each one of those specific options that patients have. So active surveillance. This is really born out of a knowledge that low-risk prostate cancer is unlikely to decrease the quality or longevity of somebody's life. What does it consist of? Well, it's close monitoring of men with low-risk prostate cancer. We follow their PSA. We perform repeat prostate biopsies, and we sometimes use prostate MRI in this as well to help us follow these patients. And really the key to this is we're following you as long as you're sort of staying in your path and your disease is not progressing or advancing. We're going to keep you on active surveillance and avoid you having to have the side effects of treatment. But if your cancer increases in volume or grade, or you yourself have anxiety, or your surgeon has anxiety about your disease, well, then you can move on to treatment. And so that's the beauty of active surveillance. And I think it's important to sort of think about the history, and I think it informs us a little bit about why are we doing active surveillance? Because I think some patients hear cancer and they think, well, you have to do something about it. You need to do something about it. So you can think about in the pre-PSA era, before we had PSA, so pre-1980s, we found prostate cancer only when it was very advanced, usually. And so there were surgeons operating on prostate cancer, but we really didn't have great results. We weren't finding it when it was just within the prostate. 1980s, PSA comes around. That combined with us taking a feel of the prostate, we were able to screen and identify men with clinically localized prostate cancer. So in the 90s, early 2000s, basically if you had prostate cancer, you were going to get some form of treatment. And what we found after following these men was that we were treating a large number of men without necessarily improving their longevity of life or their quality of life, but we were giving them side effects from the treatment. And so really the goal of active surveillance is to avoid treatment in men that have a low risk of benefiting from the treatment. And all of this obviously is we're trying to balance risks and benefits for the individual patient. Another one of the treatment options that we talked about is radiation therapy. Radiation therapy can be given in a variety of different ways. One of those is brachytherapy or seeds, which you might have heard about. External beam type radiation therapy, which is sort of more commonly in the medical field talked about as IMRT or intensity modulated radiotherapy. There's proton therapy, which is a different type of radiation, but again also an external beam. And then there's CyberKnife or hypofractionated therapy, basically IMRT but done at higher doses, smaller number of doses. And then with radiotherapy, this might be with or without androgen deprivation therapy, which is shots that lower your testosterone level essentially down to zero, and that can be for a period of time anywhere from 6 months to 2 years, and it depends on the grade of disease that you have. What we found is that it's better to give radiation therapy with the hormone therapy for men with intermediate or high-risk disease. We don't use it in low-risk disease because there hasn't been that benefit shown. Here's an example of the brachytherapy. It's a procedure usually done by a radiation oncologist, and sometimes a urologist will be there to assist. And basically, you're trying to implant or put these seeds evenly spaced throughout the prostate to give an even distribution of the radiation. It's a procedure. It involves anesthesia. Like I said, the seeds emit radiation over a short distance. It's really ideal for patients with low-risk prostate cancer, since only the prostate itself is treated. It's not ideal for a large prostate. It's hard to reach certain areas of the prostate when the prostate's so large to implant the seeds. Some centers will combine brachytherapy with external beam to sort of give that advantage of treating outside the prostate as well. External beam radiotherapy, that is generally given on a daily basis, Monday through Friday, in small doses of radiation, and that's over an 8-9 week period. The prostate is targeted, but surrounding organs receive a dose of radiation as well. This is a sort of picture representation of IMRT, and a radiation oncologist will plan their targeted treatment, and basically the area of the red shows you the highest dose of radiation, and that's the prostate. And so they're trying to conform the highest dose of radiation to the prostate. They're trying to spare the surrounding organs. You can see they're trying, but they can't completely exclude the surrounding organs from doses of radiation. So the bladder gets some radiation, the rectum gets some radiation, the urethra gets some radiation. And so that has to do with some of the side effects that we'll talk about. Proton therapy, it's taking advantage of a unique property of photons that allows for a tighter radiation field. Conceptually, it was a really promising idea, but it really hasn't shown to have decreased side effect profiles like we would expect or sort of we're hoping for. It is by far the most expensive way to have your prostate cancer treated. And so if it's going to be the most expensive, we would say there should be some data behind it that supports why it's so expensive and why it's a needed treatment. So it's argued about. And then CyberKnife for hypofractionated. It's high doses of radiation given in small number of treatments. It requires placement of a fiducial marker to ensure the accurate delivery of the radiation dose, because if you're giving much higher doses, you better be certain you're hitting the prostate consistently with those high doses. It's newer technology technique, and it really doesn't have the long-term data behind it that our conventional radiotherapy has. So it's hard to say what we would say about it in the 5, 10, 15 years down the road. So what are the radiation benefits? Well, radiation isn't surgery. If you have let's say a heart condition that precludes you from having general anesthesia, then radiation is an option for you. During the treatment, there's really minimal immediate symptoms, side effects during the treatment. So it's generally a well-tolerated treatment during it. The negatives. Time commitment. You can imagine Monday through Friday, 8-9 weeks. It's a significant time commitment. Each individual session is not very long, but some people with their work, et cetera, just can't do that. The need for androgen deprivation therapy in intermediate and high-risk disease, that's something that you don't necessarily have to have with surgery. The side effects, and we'll talk about that in comparison from surgery and radiation, the side effects for radiation don't generally happen immediately, but develop with time. There's a risk of erectile dysfunction, a small risk of urinary incontinence, but the potential long-term side effects are what we worry about with radiation, 5, 10, 15 years down the road. Those include scar tissue formation in the urethra, developing blood in the urine, blood in the stool, rectal-type side effects, or secondary malignancies like bladder cancer or rectal cancer. And the problem with these side effects is there's not really an easy fix. I can't go in there surgically and fix it. Radiated tissue just doesn't heal normally. consider is that if you have BPH or enlarged prostate symptoms that develop later on, having had radiation limits what we can do for you from a urology perspective. I can't go in there and do a TURP to scrape out the inside of your prostate the same way I would if you hadn't had radiation because of that inability for it to heal adequately. So that's something to consider. And then what happens if cancer returns after radiation therapy? Well, you can't get more radiation. They've sort of maxed out how much radiation your prostate, and some would argue even the pelvis can get. So surgery is possible, but it's not commonly performed in this what we call salvage setting. There's a high risk of rectal injury. You're almost certainly going to be unable to get erections, and you're going to have a high risk of lifelong urinary incontinence. So it's not an ideal surgery that you want to be performing on patients. Cryotherapy or freezing the prostate is an option. And then the other option is lifelong hormone therapy or androgen deprivation therapy if cancer were to recur after radiation. So surgery. Different types or ways of us doing the surgery. There's open surgery. We're going to open lower abdominal incision. There's laparoscopic prostatectomy through small incisions. Laparoscopic prostatectomy, where we're sort of standing at the bedside using straight instruments, though, has really been essentially abandoned. I mean, there are some people in the country that still do it, but it's technically very complex, and so with the advantages of robotic laparoscopic prostatectomy, that's pretty much gone by the wayside. So robotic laparoscopic prostatectomy is the way that the majority of prostatectomies are performed nowadays in the country. The advantages for us for robotics is that there's less blood loss, less postoperative pain, easier operation. So laparoscopic, and some would argue easier than the open. So what do we do during the surgery? Well, and just to reinforce this is what I do. You know, this is what I became a urologist for, to be able to do these type of surgeries. So we remove the prostate, we remove the seminal vesicles, which are these appendages that hang off the back of the prostate. We can remove lymph nodes in the pelvis when that's appropriate, and we can also perform nerve sparing. And nerve sparing is there's important nerve vascular bundles that run along each side of the prostate. They're important for erections. It does require several hours of anesthesia and usually a one-night stay in the hospital. And it usually requires having a Foley catheter in place for about a week after the surgery. This is what I do. You know, there's one robot on the market, and it's an intuitive type robot. Basically 5 small incisions spread across the belly. And through those incisions, I'm able to do the surgery and then take out the prostate through extending one of the other incisions just above the belly button a little bit to allow us to remove the prostate in the end. There's a little bit of sort of a cross-sectional anatomy of the prostate, and talking a little bit about that nerve sparing. So the prostate itself is here, your urethra runs through it, and then, like I said, on each side, sort of down at the bottom, are these neurovascular bundles. Right underneath it is the colon or the rectum, and so we're having to balance removing the prostate, not getting into the rectum, and when appropriate, trying to spare these nerves. So what are the benefits of surgery? Well, we gain more detailed pathologic information. We've got the whole prostate out. The pathologist can look at it all. They might say that your cancer was consistent with the biopsy, or they might find more high-grade cancer, or they might even downgrade it and say, no, we really think it was more lower-grade type cancer than what was seen on the initial biopsy. We would notice the cancer just confined to the prostate as it started to go outside the capsule of the prostate, and we know if the margins were negative, had the cancer start to extend to the edge of where we'd cut. Nerve sparing, like I talked about. And ideally, you know, if the cancer is confined to the prostate, we've removed the prostate, that is ideally the only treatment that you would need. If cancer does return, you can get radiation therapy if needed as an adjuvant treatment, which we think is a benefit. So what are the negatives to surgery? Well, it's surgery. It involves anesthesia, there's blood loss, there's risks of surgery, and there's nights spent in the hospital. Like I said before, you have to have a catheter in for about a week. And with surgery, the side effects that we see are generally sort of front-loaded. Once that catheter comes out is when men will see the main side effects of urinary incontinence and erectile dysfunction. But the side effects generally get better with time, as opposed to radiation where side effects can stack up with time. So initially, I tell men that they're going to have to wear some sort of incontinence product for a short period of time. Usually over weeks to months, they will regain their continence, but a small percentage of men don't. And that small percentage of men may have to either continue to wear pads or have other procedures done to help with their urinary control. Erections, almost certainly you'll have a decrease in the erectile ability. We do things to try to help prevent further loss or decline in your erectile function, like the nerve sparing and things like what we call penile rehab. But generally speaking, men are able to take medicines like Viagra type medicines that can help them regain their erectile function even after the surgery. And then the other category that I was talking about, in that category I put cryotherapy, and that I'm talking about is freezing the prostate, but as a primary treatment for the treatment of the prostate cancer. HIFU, which is a high frequency ultrasound treatment, and focal type therapy. These are less well studied. Are they options for men? Yes. It's just they're not the sort of gold standards for treatment of prostate cancer. So I think you have to go into that knowing that. But are they options for treatment for men? Yeah, they are. But each one carries its own considerations. So, which one of these treatments is right for me? Well, you need to consider multiple factors: your age, your life expectancy, your prostate size. Do you have any BPH symptoms or urinary symptoms? What's your medical history, surgical history? And even after considering all these considerations, like I said, you generally have options with regards to what you can choose for treatment of your prostate cancer. What I recommend for all my patients after I give them a diagnosis of prostate cancer is to get educated. I like the American Cancer Society website. I think that they have a lot of great information on it. If you go to that, on the upper left, you can click on cancers A through Z and then find prostate cancer. And they basically go in depth into all the various aspects of prostate cancer, from diagnosis to treatment, and pros and cons of each individual treatment. And that's what I try to have my patients do as sort of homework before they come and see me for our initial talk, so we're sort of on the same page, coming in informed about your options. And then we can, as a patient and a physician, talk about the finer details of your individual health that might help us come to a conclusion about what's the right choice for you. Like I said, talk with your doctor, talk with your friends and family, and then try to make an informed decision. That's what I want to leave you with, is try to be your own patient advocate and get very well educated on it, and try to make sure that when you're making your decision, you feel like you've learned as much as you can about the topic. And with that, I'll take any questions that you guys may have.
At this point, I'm going to stop our Facebook video because no one's watching. But before we do this,